Welcome to the Bioethics Babe podcast, where we examine the tough questions in human flourishing in light of science, faith, and culture. I'm your host, Darina Grosso-Agnew. Now let's dive in. How easy is it to obtain abortion pills online? Could someone posing as a minor order them? Are patients adequately screened for serious medical conditions before they are prescribed? And what safeguards, if any, still exist to protect women and their preborn children? Those are the questions that led today's guest, Dr. Christina Francis, to go undercover. Dr. Francis is a board-certified OBGYN, CEO of the American Association of Pro-Life Obstetricians and Gynecologists, and a practicing OBGYN hospitalist. She previously served for 3 years as the only OBGYN at a mission hospital in rural Kenya, and has dedicated her career to caring for women while advocating for evidence-based, life-affirming medicine. In a first-of-its-kind undercover investigation, Dr. Francis posed as a 13-year-old girl with multiple serious medical risk factors to test today's mail-order abortion pill industry. What she found raises significant questions about patient screening, informed consent, medical oversight, and the safeguards that have been removed in recent years. Today, we'll walk through her investigation, discuss what it means for women, girls, and their preborn children, examine the FDA's ongoing review of mifepristone, and explore what compassionate, ethical healthcare should look like. Dr. Francis, welcome to Bioethics Babe. Dr. Francis, welcome to Bioethics Babe.
Thank you so much for having me, Irina. It's great to be on.
For listeners who may not know you, tell us about yourself and what led you into obstetrics and gynecology.
Yeah, well, it's one of my favorite things to talk about because I feel that I'm very blessed to really have the best job in the world. I went into medicine to do medical missions, actually. I wanted to work overseas in a missions hospital. And so when I started my medical school training, I actually wasn't even thinking about OBGYN at all. I really was kind of focused on, what would give me the broadest base training for being able to work at a mission hospital. And so originally I was thinking about, family medicine or internal medicine, pediatrics, something like that. And when I was a second year medical student, for people who don't know, typically you really start doing your clinical work in your third year of medical school. But in my second year, I was shadowing a family medicine physician, working with him in his office. And he got a call from the hospital that one of his patients who'd been in labor was getting close to delivery. And so he said, all right, let's go to the hospital. And so I went with him and was able to be in the delivery room. And I was kind of standing back in the delivery room and watched the delivery happen. And, here's a woman that I didn't know at all. I'd never met her before walking into her room that day. And I just started crying because I thought it was the most beautiful, miraculous thing that I'd ever seen. And there was an older kind of seasoned labor and delivery nurse that was standing next to the baby warmer. So she was standing close to me. She was waiting to take the baby over to the warmer. And she saw me crying and she leaned over to me and she whispered in my ear and she said, "Oh, honey, if this makes you cry, you need to do this for a living." And so I've often said in that moment, actually, my specialty chose me. I didn't choose my specialty. It really did choose me. And from then on, when I did my clinical rotations, it really just stuck with me. And I did not enjoy anything else as much as I did getting to walk with women really through all phases of their life. My favorite part is taking care of them during pregnancy and their delivery, but really getting to walk with them through all phases of life and realize too that actually did provide wonderful training for the mission field because as OBGYNs, we're surgeons, so you learn surgical skills and also, in most developing countries, really the populations that need the most from a healthcare perspective are typically women and children. So it actually was wonderful prep for what I thought was going to be, a lifelong service and work in the medical mission field.
Well, speaking of that, so you did spend 3 years as the only OBGYN at a mission hospital in rural Kenya. before returning to practice in the US.
Mhm.
How did that experience shape your philosophy of caring for both women and their children?
Yeah, it really was so formative in who I am today as a physician, and really I think helping me gain a deeper appreciation for this profession that chose me, that I went into. And it still has a really special place in my heart. So I had the honor of serving at a mission hospital called Kapsawar Mission Hospital, which was in a pretty rural part of Kenya. But the population that we served was about 300,000 people. And so, imagine that for those of us here in the US, imagine having one OBGYN for 300,000 people. I mean, it really is unimaginable, I think, for us. Thankfully, that didn't mean that I did all of the deliveries for those 300,000 people. I would have never slept. But I worked with amazing nurses, and we really were kind of a referral hospital. So for women who maybe weren't able to deliver out at smaller community health centers, what I really truly realized, I think, during that time was so many things. But one, I really learned the importance of uh, putting my hands on my patients in a good way, and doing a physical exam. We lacked many of the resources that I have here in the US, imaging modalities and labs and things like that we can do here that help us determine a diagnosis. And there we really had to rely on our interaction with our patient. So talking to them, listening to them, doing a thorough physical exam. I remember shortly after I came back to the States, we had a patient who had a postpartum hemorrhage, and we had the labs and we had ordered them, but we were waiting on them to come back. And I pulled her eyelid down and looked at what's called her conjunctiva and told the nurse what I thought her hemoglobin was going to come back as. And I was right. And when it came back, the nurse said, "How on earth did you do that?" I said, "Well, I had to do it all the time in Kenya because a lot of times the hospital wouldn't be able to run the labs that I needed." So those kinds of things definitely impacted who I am today as a physician. But I also saw what women truly need in order to have healthy pregnancies and healthy deliveries. And oftentimes it's very basic things. They need good prenatal care. They need early access to prenatal care. They need access to ultrasound, access to blood products when they have postpartum hemorrhage, treatment of their blood pressures, things like that. I did not see that there was a need for abortion in order to ensure, healthy pregnancies or prevent maternal mortality. So what I truly saw there was that because unfortunately I had several mothers during my 3 years that passed away from complications of pregnancy, some as they were arriving to the hospital, some after they arrived. And really, truly, in nearly every case, their deaths likely, had they had access to care sooner and access to more resources, could have been prevented. And so, I think that's one of the big things. And then the final thing I'll say that really kind of impacts what I do here is abortion was not an accepted part of the culture. It certainly was done, I think it's done in every place in the world because of living in a sinful, fallen world, and women feeling like they have a lack of resources. But it was not accepted. And while I was living there in 2010, Kenya was looking at adopting a new constitution for the country. And part of that new constitution was some change in their laws regarding abortion. So abortion was completely illegal for any reason, other than, of course, doctors could intervene to do early deliveries and things like that if a mom's life was in danger. But otherwise, there was no option for a legal abortion in Kenya. And they started to change the wording at the urging, actually, of American NGOs, pro-abortion NGOs. And they opened up that health exception, which we all know in the States, in the Dovie Bolton case, was really what allowed abortion for any reason. And so, I started having conversations with my Kenyan friends about that and said, just so you understand, this is what that means and this is what it will bring. The most disheartening thing for me in that whole process was, at the time, our vice president, Joe Biden, came over to Kenya and was talking to Kenyans about why they needed to adopt that particular language on abortion in their constitution. And first of all, I found it very offensive. What role does our American government have in trying to tell another country what their constitution should and should not say? But also just the fact that it was very clear that it was American and other Western NGOs and groups that were trying to force their ideologies on a country that really didn't want it. And so I think that was the first time my eyes were really open to the impact that abortion policy here in the United States can have on abortion policy around the world.
Yeah, and I remember when I did some work and presentations at the UN Commission on the Status of Women, and how much Western thought about abortion and transgender ideology, et cetera, was being pushed on to other countries. So I totally understand. So today you're the CEO of AAPLOG while continuing to practice as an OBGYN hospitalist. How does remaining in active clinical practice shape your leadership and advocacy?
Yeah, such a great question because people ask me all the time, why are you staying in practice? Isn't it a little bit too busy? And it is quite busy, but thankfully, because of working now for the last 10 years as an OB hospitalist, which means I don't see patients in the office anymore. I just take care of women in the hospital, mostly pregnant women, but also see women in the emergency room with various obstetric or gynecologic emergencies. That makes it possible for me to do both. So working as an OB hospitalist, very part-time now because of my work with AAPLOG. But it's so crucial for a number of reasons that I continue to be in practice. First of all, I love it. And I just would miss it so much if I gave it up completely. And so I really wanted to hold on to the ability to continue to take care of patients in a way that allows me that direct interaction with them, to be able to walk with them through their labors and their deliveries and things like that. But also, it helps me continue to ensure that I'm up on the latest medical evidence regarding care in pregnancy, care for gynecologic conditions that we see in the hospital, things like that. That would be very easy, I think, to, not that you couldn't stay up on it if you weren't in current practice, but it would make it more difficult to stay current on that. And the other thing is, I do think it brings a level of credibility when I am speaking to people who are opposed to me on the issue of abortion, or testifying in front of Congress, or, things like that, speaking at conferences, things like that. It does bring a level of credibility to be able to say, for instance, I know one of the big topics we're going to talk about today are the harms of the abortion pills. I can honestly say that within the last month, I have gone down to the emergency room to take care of a patient who is suffering from a complication of the abortion pill, and talk about that from my own personal experience. And, that's something that people can't deny, if I'm seeing it myself versus just reporting maybe what other people are seeing. So I think there's a number of reasons why it's important for me to stay in practice. But again, I also just continue to love the opportunity to be there with women during one of the most exciting, but oftentimes also very scary parts of their life, when they're in labor and going through delivery, or, when they might be experiencing a pregnancy loss or something like that. It's a true privilege and honor to be able to be there with my patients through all of those experiences.
Yeah, and I think it's so powerful that you are able to have that experience with them, and given the work that you do and the knowledge you have of, for example, the abortion pill industry, et cetera, to see those two worlds collide, and it's not just a theory. These policies are actually affecting real women, real children. And so you recently went undercover to investigate the online mail order chemical abortion pill industry. What prompted you to conduct this investigation?
Well, we talked about it as a team, and certainly there have been a lot of videos out there on social media showing how easy it is to get these pills. I personally have seen videos of men getting on just to prove that they could get the pill as a man. There was a reporter, I think, at the Daily Caller who did a whole series on just how easy it was to get your hands on these pills. So that has been shown. But I would say one of the things that prompted us was the fact that the FDA has yet to act to bring this under control. That, our current administration, we've been a bit disappointed, certainly, as an understatement, in their response to this. And so, I think the need to continue to show the harms that this is having, that, again, doctors like me who are seeing women in the ER are seeing on a regular basis. And so we wanted to continue to highlight those dangers. But the other thing that we were talking about is, I said to my team, I wonder if any of these sites that are dispensing these drugs, if someone had true contraindications. So true medical reasons why taking these drugs would be even more life-threatening for them, for the woman. Would there be, at any point, would they put a stop to it, these websites, that are dispensing the drugs? Because they claim that there's medical oversight. And, people continue to talk about mail order abortions as telehealth or telemedicine. And, I think for the general public, for somebody who isn't deeply entrenched in this issue like you or I are, when they hear telehealth or telemedicine, they probably picture what I picture for that, which is I'm sitting down at a computer with a qualified medical professional, on the other side who's talking to me, asking me personalized questions, assessing my health history, all of that. And we really wanted to show, or when we went into it, is there any kind of medical oversight? We knew that there wasn't going to be real-time interaction with a medical professional, but we really wanted to see for somebody who has true reasons why these are even more life-threatening than they are at baseline, would there be, at any point, would they put a stop to it?
Mm-hmm. And so let's just dive into the actual investigation. You posed as a 13-year-old with serious medical risk factors, including severe anemia, an IUD, multiple prior C-sections, and blood thinner use. Why were those particular conditions important to include?
Yeah, absolutely. Well, this really highlighted, honestly, it shocked even us that I was able to get the pills, which I know we're going to talk about that here in just a little bit. But we really chose as many of the risk factors that we could. So first of all, a very young girl. So obviously, just the fact that she's pregnant, that should put off warning bells. As physicians, we are mandatory reporters if we suspect sexual abuse. If I have a 13-year-old who's pregnant, who's in my office, the first thing I'm going to suspect is, has she been abused? Not that it's 100% of the time, but very frequently, if you've got someone that young, a girl that young who's pregnant, there's been abuse going on. And so we wanted to see, are we going to be screened to see, has there been sexual abuse at all, or any method that could be reported? Obviously, a 13-year-old is also not going to fully grasp the gravity of these high-risk conditions that I supposedly had. So what kind of informed consent is happening? Is it being tailored to the fact that this is a 13-year-old doing it versus someone in their 40s like me who's doing it, who would have hopefully a better ability to be able to grasp the severity of these conditions? 3 previous C-sections put someone at risk for a uterine rupture if they take the second drug in the abortion pill regimen, misoprostol. So that's why we put that in there. I put in multiple risk factors for that this could be an ectopic pregnancy. So that I had an IUD in place or an intrauterine device. When a woman gets pregnant or a girl gets pregnant, if she has an IUD in place, it's much more likely to be an ectopic pregnancy. Also said that I had a history of an ectopic pregnancy, which would further increase my risk of an ectopic. That would be life-threatening. Mifepristone and misoprostol do not treat ectopic pregnancies. And the symptoms of an ectopic are the same symptoms that a woman or a girl will experience when she's having a drug-induced abortion. And so she wouldn't be able to know when she has those symptoms that it's because of an ectopic and not because of the abortion process. And then the fact that I said I was on blood thinners, that would mean, and especially, I also said I didn't know how far along I was. And then they just said, take your best guess. So let's imagine I'm 18 weeks pregnant and I take these drugs to induce an abortion. Even without being on blood thinners, I'm going to be at significant risk of more severe hemorrhage because of how far along I am in my pregnancy, and a retained placenta, which further increases my risk of bleeding. That's at baseline. Now imagine on top of that, you add blood thinners that actually make it nearly impossible for my body to clot blood to stop bleeding. That is going to be somebody. And then you have a 13-year-old who, how is she supposed to know how much bleeding is too much and how much is normal? And she's probably going to be scared for anyone to know what she did anyways, so she's going to keep it quiet. So we just thought, all of these risk factors put together, plus I'm anemic. Oh yeah, and I was anemic. So I'm starting out the process with very low blood count, which means I'm going to be at a much higher risk of dying from hemorrhage than if I started out the process with a higher blood count. So all of these things. Now, first of all, if someone had actually looked at any of this, a 13-year-old with 3 previous C-sections and an IUD and a history of an ectopic, I mean, come on. Somebody would have been like, they're screwing with us if anybody had looked at that. if anybody with any kind of medical background had looked at that, they would have said, this is way too dangerous. And we could be, if for no other reason, if they didn't even care about the girl, we could be held liable for giving a drug to someone. If I gave a drug that did what mifepristone does to a patient with that history, it would be open and shut medical malpractice case. And so, we really wanted to see, and it was very obvious through the process that there was no oversight whatsoever. No one was even looking at any of those responses.
Wow. And I mean, like you said, even one of those factors should have raised a red flag for if someone was actually looking at this information. But all of them together, I mean, that's how crazy this is, that all
Right.
of those together still didn't raise any flags for anyone with these companies.
Absolutely. And no ID check. I mean, I like to think that maybe I don't look my actual age, but I don't think that I look 13. So, so no ID check whatsoever to even confirm, my age or who I am. I could have just as easily been an abuser or a trafficker that was getting on and ordering these pills.
And so no age and no ID check. Were
Right.
you ever asked that you were pregnant?
There was a question about whether or not I was pregnant, but then it also said if you're unsure or you just want to have these around in case you become pregnant in the future, that you could do that as well. But no need. I kind of thought I was going to have to submit some kind of proof, like a positive pregnancy test or something like that. No confirmation whatsoever that I was even pregnant.
Wow. Were you ever required to confirm your gestational age, and why does that accurately matter if to accurately date your gestational age before these drugs are prescribed?
Yeah. Well, I'll start with the second part. So we know very clearly, and this is not from pro-life researchers, this is from research that's been done across Europe, but also research done in the development of the drug mifepristone. We know that beyond about 8 weeks of pregnancy, for every week further in pregnancy a woman is when she takes mifepristone for an abortion, the rate of complications goes up exponentially. So if you kind of look at the complication curve, it's kind of a flat line up until close to 8 weeks, and then it just shoots straight up. And so it matters for, again, even if somebody's not opposed to abortion, even just for informed consent purposes, that informed consent is going to look much different for a woman if she's 6 weeks pregnant than it will if she's 18 weeks pregnant, because her risks are completely different. And so it really does matter how far along in pregnancy a woman is to know what her risk is in taking these drugs of things like hemorrhage or heavy bleeding, infection, sepsis, which is a blood infection, or even retained placenta, like I said before. And that can require an emergency surgery to resolve. So it's very important that someone know how far along they are. And no, there was no, so I did put in, they asked you to put in the first date of your last menstrual period. I put in a date that I knew would make me about 20 weeks pregnant because I wanted to see if they would let me keep going. They did say that they won't dispense pills beyond 14 weeks, but I also had said that I was unsure. And so then there was a little blurb that said, but if you're unsure, just give your best guess. And built into the system is a back button. So not like your normal web browser back arrow, but built into their system is one that says back. It lets you go back and change your answers. So if I'm a scared young girl who maybe even knows that I'm 20 weeks pregnant, and I put that in and they say, we won't give it beyond 14 weeks. And I see that back button. Well, then what do I have to do? I just have to fudge it by 6 weeks, right? And I can go back, change the date, which is in fact what I did. And then you can keep moving forward. They don't say anything about why did you change your answer, or anything like that. I did that several times for several different questions just to see if I do that a bunch of times, is that going to put a stop to it? And it didn't. And I think it's important to point out too that they openly advertise, this is on Aid Access, they openly advertise that they give the abortion pill regimen through 14 weeks of pregnancy, even though in the United States it's only FDA approved through 10 weeks of pregnancy. So they're openly advertising that they're giving it a full month beyond the FDA approval.
Wow. And also, obviously, a young girl wouldn't know why there's these limits and what risks this poses to her health. She
Right.
might just change it on there as saying, well, no one's going to know, but she doesn't realize that those were
Right.
put in place for a reason. And actually, they're not even safe enough, right? We'll talk about the FDA and how it went from 7 weeks to 10 weeks. And as you've been describing. They're giving these pills out 14 weeks and even beyond, and so it's crazy how much of a risk this is to women's health.
Right.
And of course, there was no requirement to obtain an ultrasound or even talk with a physician during this process, right?
Yeah, no requirement. They did, to their credit, I suppose, if you can give them any credit, they did say, like, you should have an ultrasound, after I said that I had an IUD and a history of an ectopic pregnancy. But again, if I'm a 13-year-old or even if I'm a 25-year-old who says, like, why would I need an ultrasound? Especially when there are groups like the American College of OBGYNs, ACOG, out there saying ultrasounds are medically unnecessary before abortions. When you hear that coming from some doctors out there, it'd be so easy to just ignore that. And again, they don't do a good job on these websites. And this is why there needs to be an actual person talking with women who is trained and qualified to give them counseling on this. There's really no way that a woman going through this who presumably doesn't have medical knowledge is truly going to understand the risk that she is putting herself at. And certainly there was no information given about what's actually going on with the baby that's developing and growing inside of her as well, which also has to play a part of informed consent.
Mm-hmm. Yeah, so no ultrasound, no discussion about the medical history, no
Right.
discussion about the significant risks. And so you went through the process, you ordered the abortion pills. After completing the order, what arrived in the mail?
Yeah, absolutely. So when you get to the end, first of all, you had to agree to all of these things, many of which we highlight this, detail this in the video, many of which actually were factually wrong, that they're telling women. At the bottom, it said that, once you hit submit or when you submit your request, your information will be reviewed by a healthcare professional. And then if you are approved, you will get an email with a payment link and to confirm your mailing address. So I hit submit, and literally within about a minute and a half, I had the email in my inbox with the payment link and to confirm my mailing address. So obviously it's not being reviewed by anybody. It arrives within a minute and a half. That's an automatically generated email that is coming to me. So I got on and I paid, and 4 days later, in my mailbox in the state of Indiana where I live, where abortion is largely illegal, almost completely illegal, a package arrived from a address in Los Angeles, California, that when we looked on Google Earth, it was just this sort of rundown looking building with no business name attached to it, no prescriber information. I got a generic looking pill bottle, the little orange pill bottle with a label printed on it that looked like it had been printed on a home printer that was running out of ink, by the way. Like you could really kind of only see about half of what was on it, of misoprostol, and then a box from Gen BioPro, one of the companies that manufactures mifepristone, and a QR code. And the QR code had just very basic instructions of how and when to take the drugs. And I think it should be pointed out that I got, I believe, 12 tablets of misoprostol, 200 microgram tablets, which would be a total of 2,400 micrograms. That is a lot of misoprostol. And the reason they sent that much was because they said, you take the mifepristone, 24 hours later, take 800 micrograms, so 4 tablets of the misoprostol. But then they gave you extra so that if the woman did not pass the baby and the pregnancy tissues, which how is she supposed to know if she passed everything, then the instructions were to just keep taking misoprostol until you pass everything. So that's not appropriate care for women. And then the only other, no scheduled follow-up. The only other thing they said was, if you have a temperature, I think it was over 102 for more than 24 hours, which by the time you wait that long with a temp that high, there's something very serious going on. Or if you have this amount of bleeding, then just go to the emergency room. And when you go to the emergency room, you can just tell them that you're having a miscarriage. You don't have to tell them that you took these drugs.
That's crazy. So obviously they didn't want to take any responsibility if there were complications, right? What were the instructions sufficient for someone with no medical background?
Maybe somebody could try to make the claim that they were sufficient. I mean, it certainly laid out like how to take the drugs, when to take them, that sort of thing. But again, the knowledge, like you have all this extra misoprostol. What if someone says, well, if 4 is good, 10 is probably better, and takes it all at once, especially somebody with 3 prior C-sections. She's probably going to rupture her uterus, which could lead to her dying because of horrible bleeding inside of her abdomen. But also just the lack of follow-up and the lack of clear instructions of really specific things that somebody should be looking out for. These could be signs of sepsis. This could be a sign of a life-threatening infection, things like that. Telling somebody to wait. Because of my medical background, I know you don't tell somebody, especially in this particular scenario, you don't tell somebody to wait until they have a temp of 102 or higher for more than 24 hours. Someone without medical knowledge would think, okay, well, that must be normal to wait that amount of time, even if I have a severe fever. So in that sense, I would say, no, they were not sufficient. And also no opportunity. I mean, there was an email that said, oh, if you have questions, you can email this. And it was a strange looking email back. But again, how do I even know who's answering that? How long is it going to take them to answer? Women and girls who are being given this high risk drug, at the very least, certainly deserve a qualified medical professional that they can get a hold of 24/7, whether it be that particular person or an on-call covering person, to ask questions immediately of and get immediate responses.
Mm-hmm. I'm curious now to see if you did email that email, how long it would take, who would answer, what the content would say. So maybe that would be a follow-up
That's right.
investigation.
A follow-up investigation. That's right. Absolutely.
So basically, as you mentioned, they were instructed to seek emergency care if serious complications occurred. Does that effectively shift responsibility from the prescribing, entity? I wouldn't even call it a healthcare professional, since we don't even know who's prescribing this. Is that shifting the responsibility from that entity to emergency physicians who have never met the patient?
100%. It's what we actually call in medicine patient abandonment. And it is not only unethical, but it can be illegal actually if you don't take care of a patient. I mean, we have so many rules within medicine, even like if I had an experience, this was several years ago when I was still seeing patients in the office, that I had a pregnant woman who I've seen during her pregnancy who was just actually very verbally abusive with my staff every time she came into the office. And she actually had a pretty hard life. And, so we really tried to do everything that we could to support her, but she was extremely disruptive every time she came into the office. And it was just very inappropriate with my staff. And, there is a process in medicine that you can fire a patient for a variety of reasons, and that's one of them. But actually, during a pregnancy, you are not allowed to fire a patient. You have to see her until she comes back for her 6-week postpartum visit. And then if that behavior continues beyond that, then, you're allowed to fire the patient. So I just bring up that scenario to say there is this responsibility that we have as physicians to take care of our patients, even when they're being verbally abusive to us or to our staff. We have to take care of them. You can't just abandon the patient, especially when you, as the physician or the medical professional, have actively intervened, either done surgery on them or given them a drug or a quote unquote treatment that then leads to a complication. You have to manage that complication or arrange for someone else to care for that complication by direct communication. And it's interesting because, I brought up AAPLOG earlier, and they have a whole paper out about handoff, communication during patient handoff, and how that communication has to happen. Otherwise, we increase, medication errors, we increase patient harm, all of this. But yet on this issue of the abortion drugs, they don't believe that any kind of handoff is necessary. And so what happens, as you said, Arena, is that women are told to just show up to their local emergency rooms. Even if they're honest about what happened, that they took these drugs, even if they got them from an actual abortion provider at a facility whose name they know. I've had this experience. You try calling, you can't get a hold of anybody. You can't get anyone to talk to you as the physician trying to understand what happened to this patient. But of course, when they order them online and they come from some random address in Los Angeles with no prescriber information, you have no one to talk to about that. And so, for those of us then that are seeing the women who come into the emergency rooms, of course, we want to provide her with the best care possible and take good care of her. But we really are flying blind when we don't know exactly what happened. And so it really puts us at a disadvantage, and it impacts patient care. And in fact, there was a paper that came out from the Charlotte Lozier Institute that looked at Medicaid registry data and showed that their most recent one showed that 80 of abortion complications were miscoded in the emergency room as miscarriage complications, likely because women are being told to lie when they come in, or maybe the doctor just didn't know when she came in and just made an assumption, and didn't ask about the abortion pills. But another one of their papers showed that for those that were miscoded, they actually had a higher rate of hospitalization than the ones that were appropriately coded as abortion complications. So to me, that says that the doctor not knowing that the woman had taken the abortion pill and now was having a complication, and either assuming or working under the impression that it was a miscarriage, that actually negatively impacted her care, or she had a more serious complication. So this isn't just about it isn't in fact at all about needing to know that someone had an abortion for some reason outside of being able to provide her with the best medical care possible. This is about how important it is for doctors to know what's going on, to know that patient's history and know exactly what they took so that we can provide them with the care that they absolutely need.
Wow, and it's irresponsible for them to tell them, just say it's a miscarriage, because it's actually potentially harming the care that they're going to receive, on top of the fact
Absolutely.
that they're not actually being helped by a real person in real time. And
Absolutely.
also, what crossed my mind when you're saying that more misoprostol came in than she would need to take, I could see a teenager have the extra ones, and let's say her friend got pregnant and she
Right.
doesn't quite know the protocol or what dosages of what, and she'd say, well, I have some extra abortion
Right.
pills, and
Right.
who knows what would happen, right? So
Right.
it's very, very dangerous. So many people have heard that a chemical abortion is, quote unquote, just like having a heavy period. How accurate is that description?
Well, I would say in the vast majority of cases, it is completely inaccurate. And really and truly, I mean, all you have to do to know that it's inaccurate is talk to a woman who's been through it. Or even, saying that is like telling, and now I want to be very clear what I'm saying. I'm not saying that an induced abortion is the same thing as a miscarriage. Certainly, they are very different. But that would be like telling a woman who's having a miscarriage that it's just like having a heavy period. I mean, as far as the experience that she goes through, because in both circumstances, women are delivering their babies, when they pass their baby. Now, in a miscarriage, of course, that baby has already passed away through no fault of anyone, through nothing that was done. It just happened on its own. And in an abortion, of course, these drugs are taken with the intent of killing that baby. But essentially what women go through when they have a drug-induced abortion is they deliver their babies. And oftentimes that's accompanied by very heavy bleeding. And it oftentimes happens and the woman sees her baby and recognizes her baby. And that carries with it not only is it a very different physical experience, obviously, than a heavy period. Women report that women that have had drug-induced abortions and have also labored at full term and delivered a baby have said it felt just like labor when I was going through it. And so not only is the physical experience very different than just having a quote unquote heavy period, but the mental health experience is also significantly different. I don't honestly know that we will ever fully know the extent of the mental health damage that has been caused by now the vast majority of abortions being done via these drugs at home. Oftentimes women are by themselves. They deliver their baby. I have talked to many, many people who work in post-abortion care ministries who've said that they get hundreds of calls from women who have just had a drug-induced abortion who said, I delivered my baby. I have my baby in a little baggie. I don't know what to do with him or her. They're being told to flush them down the toilet. Of course, they don't want to do that because it's their baby. They recognize in that moment that that's their baby and then think, oh my goodness, what have I done? And now what do I do with my baby? And so the trauma that this is causing, not only in that moment, but Also, the fact that now a woman's home, her dorm room, her bathroom have become the abortion facility. And every time she goes back into that space, she's reminded of her abortion. Or even I've heard women say every time after that, they did have a period, just having bleeding again like that kind of re-traumatized them. And so, or just having, even a minimal amount of bleeding compared to what they went through re-traumatized them. So, the mental health impact that this is having is also, I think, very much underappreciated by many people, and certainly by the abortion industry that continues to push this and tell women that, it's safer than Tylenol. It's just like having a heavy period. It's no big deal. While not listening to, I would say, the increasing number of voices of women who have been through this experience who say, I was lied to. I was lied to. And now not only am I facing the loss of my baby, but now I have all of these lingering effects from having taken these drugs.
It's so horrific, and it really is patient abandonment. You're letting women carry out their own abortions. The trauma, as you mentioned, the mental and the physical implications of this and the risks
Right.
are immense. So what complications do you and other OB/GYNs commonly see after women take the chemical abortion pills?
Yeah. So the most common complications that we see and that are documented in the literature, the biggest one is going to be bleeding. So what we say hemorrhage, so significant amount of bleeding. Again, this is not like a period kind of bleeding. We're talking large amounts of blood loss oftentimes that on average the bleeding lasts 8 to 14 days, but it can go up to 30 days even or more. I mean, I've heard reports of more than that. But it can last a significant amount of time, and again, can be a large amount of bleeding, in particular if a woman takes these farther along in pregnancy. Because the farther along she is in pregnancy, the more blood flow there is to a pregnant uterus. And when you actually look at the pharmacology of mifepristone, of how it works, it actually alters the synthesis of a substance called nitrous oxide, which then, so it upregulates that, which then makes it harder for the arteries in the uterus, called the spiral arteries, to contract. So the way that the uterus controls bleeding after a delivery, after an abortion, after a miscarriage, is the uterus contracts. It's a big muscle. It squeezes those spiral arteries. It causes them to close on themselves and stop the bleeding. Mifepristone actually upregulates a substance called nitrous oxide that makes it harder for the uterus to contract around those spiral arteries, leaving them open and increasing the risk of bleeding. So again, this isn't pro-lifers making this up. This is the basic pharmacology of this drug. So bleeding is going to be one of the biggest risks. The other really significant risk is infection, which is actually what led to a black box warning being put on mifepristone, because it increases the risk of infection in general, but also from one bacteria in particular called Clostridium that can lead to an atypical sepsis picture, which is very difficult to diagnose and deadly, and has led to the death of several women actually after taking these drugs. And then there's a risk of incomplete abortion, where tissue, either parts of the baby or parts of the placenta or the membranes, things like that, are left inside of the woman. That can then lead to bleeding and infection, and oftentimes necessitates a surgery, a surgical completion of the abortion, like a D&C. And that can need to be done emergently if she's bleeding heavily or if she has a severe infection. And then sometimes women have to be admitted to the hospital for IV antibiotics. I treated a patient within the last year, probably, that had infection from, I think it was 5 or 6 different bacteria. And so she had to be admitted to the hospital for heavy IV antibiotics for several days before then being discharged home on oral antibiotics. So really significant risks associated with these drugs. Again, those are just the physical risks, not even to mention, kind of the long-term mental health risks.
Mm-hmm. And why is it important to rule out ectopic pregnancy before prescribing mifepristone?
Yeah. Well, so as I alluded to earlier, mifepristone and misoprostol, the 2 drugs in the abortion pill regimen, will not treat ectopic pregnancy. So ectopic pregnancy is when the baby implants somewhere outside of the uterine cavity where he or she is supposed to be. The most common site is the fallopian tube. And the problem with that is that as that baby grows, the fallopian tube was not designed to stretch and grow with a growing pregnancy like the uterus is. And so at some point, the ectopic pregnancy will cause the tube to rupture, and then that causes life-threatening bleeding into a woman's abdomen. And this can be something that goes from stable to imminently life-threatening within a matter of minutes or an hour. And so it's very important that when women start having any kind of symptom that might be suggestive of an ectopic pregnancy, most common would be pain or bleeding, that they be seen at a hospital, and that they be treated, oftentimes urgently, especially if there's already evidence of rupture. This is still the leading cause of death in the first trimester in pregnant women in this country, even where women have, relatively easy access to healthcare. So the problem with women getting these drugs online and taking them is that the symptoms of a rupturing ectopic pregnancy, pain and bleeding, are the exact same symptoms that she's going to be told are normal for a drug-induced abortion, which are pain and bleeding. So she's taken the drugs. She doesn't know she has an ectopic pregnancy. She starts having these symptoms. She's just going to think this is normal. And with ectopic pregnancy, they don't have a large amount of vaginal bleeding. So she's not going to see a large amount of bleeding. So she's not going to be alerted or alarmed by it and think I need to go to the hospital, and she's going to stay at home. And those minutes or hours, days that she stays at home could legitimately mean the difference between life and death for her.
Yeah, and of course, since they're not even checking whether or not there's no ultrasound requirement, etc., she has no idea whether she has an ectopic pregnancy. She's receiving the drugs anyway, as you did in your investigation. So obviously, there's a lack of informed consent because a lot of this information is not really made known, or she doesn't even know how far along she is necessarily, or where her baby is, etc. Can you speak a little bit about how, with this investigation, there could be, as you mentioned, the chance of abuse. So, for example, it could enable partners, traffickers, or sexual predators to conceal abuse and actually get these drugs to use on women.
Mm-hmm. Yeah, absolutely. Well, we know that it's happening. So, when the Biden administration first removed the in-person dispensing requirement and allowed these to become mail order abortions, there were many of us that raised the alarm to say this is going to enable abusers and traffickers to be able to get these pills and force them on women who don't want abortions. We were accused of fear mongering. That's never going to happen. Well, all anybody has to do is Google news articles over the last year. I feel like once or twice a month now, we are hearing reports of this happening. And that's just what's getting reported in the news. I mean, how often is this happening where it doesn't make it into the news? My now dear friend, Catherine Herring, has been such a brave and courageous voice in this. She was poisoned by her now ex-husband with abortion pills that he was able to get without any kind of, interaction with a medical professional. And thankfully, she only ingested them once, but I think it was 7 different times, attempted to poison her with the abortion pills. And thankfully, her daughter survived. She was born preterm and has some chronic health conditions now. But she has been an amazing voice on this, and that these mail order abortions have become yet another tool in the tool belt of abusers that they can use to force abortions on women who don't want them. There was recently a story out of Ohio of a physician, which I find makes it even worse. A physician who obtained these drugs and then literally forced them into his girlfriend, who did not want to have an abortion. And unfortunately, she lost her baby because of that. So this is being used as a tool. And, the other thing on the trafficking side, we know that many trafficking victims report having multiple forced abortions because, of course, they don't earn money for their pimps like a woman who is not pregnant. And so they are oftentimes forced to have abortions when they become pregnant. But we also know that one of the key ways for trafficking victims to get help, to get out of that trafficking situation, is through interaction with a medical professional. We've now just taken that away from them. So at the very least, if a trafficker was bringing their victim into, a medical facility where they were interacting with an abortion provider, if that abortion provider was doing their job and screening for trafficking, at least that provided a potential opportunity for her to get out of that situation. Now we've just taken that opportunity away from her. So not only are we enabling the abuse, but we are also removing one of the best chances she has of getting out of that abusive situation.
Wow. So let's shift now to talking about FDA review and what the FDA can do. So the FDA is reportedly conducting a new safety review of mifepristone. Why is this review so significant?
Yeah, well, as you said, we have gotten word that that safety review is actually happening. I think it was a little over a year ago, actually, that they originally said they were going to do a safety review. So it's been a little bit frustrating. Again, an understatement for those of us who have been watching this, that there have not been any reported results from the safety review. But we are encouraged to hear that it is actually happening now. And this is very crucial because the FDA, over the last 26 years since the abortion drugs were approved in the US, has systematically eroded safeguards that were put into place around the use of this drug. So when it was approved, the FDA recognized that this was a high-risk drug that had a lot of complications associated with it. And so they put these safeguards around it to try to reduce the risk of complications and maximize the quote-unquote benefit, although we know there is no benefit to these drugs for women or for their babies. And then they removed those safeguards despite evidence that they had that removing them would actually increase the risk to women. So in 2016, they expanded the use out to 10 weeks of pregnancy, despite knowing that that was going to increase the risk of complications. They took away the required follow-up appointments. They said that non-physicians could now prescribe it. And then in 2021 and finalized in 2023, they took away the in-person dispensing requirement and said that these drugs could be dispensed through the mail or from your local pharmacy without any in-person interaction with a medical professional. When they did that, they said, we know that this is going to lead to an increase in emergency room visits, and we're okay with that. They also said, well, since 2016, we made all these changes. We haven't seen any increase in complications, so we're justified in making this decision. The problem was in 2016, they stopped requiring reporting of complications other than death. And to our knowledge, since then, there has not been a thorough safety review conducted by the FDA into these drugs in how they're used in the real world. Real world use is oftentimes very, very different than use under very strict research conditions where every patient is screened, every patient is doing theoretically the same thing, that sort of thing. What we want to know is, what is the real world impact of the decisions that the FDA has made over the last 26 years? And that actually is supposed to be done by the FDA as part of the REMS program, the risk evaluation and mitigation strategy that mifepristone is under. And yet it has not been done. And so it's very important that the FDA do this. It's actually by law, what they have to do with a drug that is in this program. And so our hope in this review that's being done is that it is being done in a thorough, unbiased way, and that it really truly is looking at real world conditions, not the studies that it previously relied upon to make these decisions. Just as a very quick example, there were basically 5 studies that the FDA relied upon to say that it was fine for them to remove that in-person dispensing requirement. The problem is none of those studies actually looked at the actual conditions that the FDA was approving. The vast majority of the studies, actually, the women had had ultrasounds. They had had in-person visits. Then they were sent home and then the drugs were mailed to them at their home. That's not what's happening, as our investigation showed in the real world. And so it's very important that the FDA be looking at actual real world conditions and what are the outcomes.
Wow. So you're basically saying that they took away the reporting of any adverse conditions except death. So right now, they don't even have that data because they took it away. Based on your investigation, what safeguards do you believe the FDA could restore immediately while its broader review continues?
Yeah, no, I'm so glad you asked that, because what we have heard since last year from the FDA is, well, we can't reinstate the in-person dispensing requirement because we're doing this safety review. And yet I have yet to hear any explanation. There is no medical reason, no scientific reason why they can't do both simultaneously. Reinstate the in-person dispensing requirement now. That would just take it back to how it was pre-2021, put all the same stipulations back into place that were there before 2020. And at the same time, look back at before you put the in-person dispensing requirement in place and see what was happening with women. They have access to massive insurance claims databases that they can use. They have access to a lot of different databases that they could be using to look at, what is the actual complication rate. And so that's something that they could do immediately. That would put a stop to a lot of the problems that we're seeing with abusers getting their hands on these drugs and forcing them on women. That would at least hopefully ensure that women are having thorough medical evaluations. Now, it's a whole nother episode to talk about what kind of evaluation they actually get from abortion providers, but at least it would give them a chance at that. It would give them a chance at being in front of a person, having an ultrasound, hopefully. That is something that has actually never been required. An ultrasound has never been required by the FDA. AAPLOG has actually made the argument through a couple different citizens petitions that an ultrasound should be required because it is the gold standard for dating a pregnancy and for ruling out an ectopic pregnancy. But even if they just put back in place the in-person dispensing requirement, which they could do today, by the way, it would not take, I can't imagine it would take that much for them to immediately put it back into place. They have all the previous, forms, all of that from the FDA pre-2021. Just go back to that. They could do that today while they're doing the in-person or while they're doing the safety review. What we are calling for is that a thorough safety review be done. I actually think that if that was done honestly, that the drug could legitimately be removed from the market because of the rate of complications and because it actually brings no health benefits to women through induced abortion and certainly not to their babies. And the FDA shouldn't be approving drugs that are intended to kill human beings. That's not the FDA's job. So I think that it actually could show that. But at the very least, we think what the safety review will show is that we should go back to the original safeguards that were in place. Roll it back to 7 weeks approval, require 3 in-person visits, require it to be done by a physician, and add to that an ultrasound requirement, again, so that we don't have missed ectopic pregnancies and so that we know exactly how far along women are if they're being given these drugs.
Mm-hmm. And beyond abortion itself, what does this investigation reveal about the direction healthcare is moving when prescriptions, especially deadly prescriptions, can be obtained with so little physician involvement or no physician involvement?
Right. I think it's such a good question because, telehealth and telemedicine are on the rise. Again, this investigation showed that the way these drugs are being dispensed does not even come close to qualifying as telehealth or telemedicine. But, I think it shows that unfortunately, medicine and healthcare have been overtaken by ideologies, and that has been done at the expense of patient safety and patient care. So, when you take an ideologically charged issue like abortion or like transgender interventions, what we have seen is that there is a faction within medicine. And unfortunately, that faction includes our sort of governing medical bodies or those bodies that are seen as governing bodies, even though they really actually have no genuine authority over how we practice medicine, have pushed access, unimpeded access at the expense of patient care and patient safety. And I think this investigation is the perfect example of that. Again, even if somebody says, I think every woman should have access to abortion pills if she wants them, we should all agree that that shouldn't be done at the expense of her safety. That just because a woman is seeking an abortion doesn't mean she is deserving of substandard care. And that's exactly what this is. It's medical malpractice. It's substandard care. It is not something we would even come close to accepting in any other aspect of medicine, any other area of medicine. To highlight that, when ACOG first started pushing for that in-person dispensing requirement to be removed, they actually sued the FDA in 2020 over the in-person dispensing requirement, stating that it was medically unnecessary. They changed their guidance. At the time they sued, their clinical guidance actually said that an in-person visit was necessary. Then I think they realized, that doesn't bode well for our lawsuit. So they changed their guidance. And when they changed it, I brought it up to a colleague of mine who is pro-choice. And she and I have been able to have great conversations about this in the past. And so I brought it up to her and I said, Let me ask you this. If a woman called you and she said that she thought she was about 8 weeks along and she'd started to have some spotting, she hadn't had an ultrasound, she hadn't had any labs done or anything, but she's been through a miscarriage before, so she's pretty sure that that's what this is. And she's got kids at home. She really doesn't have time to come in for a visit, but she knows this is a miscarriage because she's been through this before. And she just wants some misoprostol for her miscarriage. Would you call in misoprostol without seeing her, without confirming that she's pregnant, without doing an ultrasound? She said, of course not. That'd be so dangerous. She needs an ultrasound. She needs labs. She needs to be seen. Why on earth would I do that? And I said, did you know that that's exactly what ACOG is advocating for women who want abortions? And she just was flabbergasted. She's like, that's not even good medicine. I said, exactly. And so, this is not something that we would accept in any other aspect of medicine outside of those things that those within medicine who are on the side of abortion or on transgender intervention, things like that have decided good medicine goes out the window. We don't even care what the evidence says. We just want access. And it really is leading to horrible outcomes and really lowering the bar of what good medicine should be. Again, those of us who are pro-life, of course, we want women to make decisions for life, for themselves and for their children. But we also believe that they are deserving of the same level of medical care as every other woman. It's the abortion industry and its allies within medicine that have said, no, those women don't deserve the same level of care. They're fine with some standard care as long as they get their abortion. And I think that feminist groups, women's rights groups, things like that should be rising up against this to say women deserve better care than this. And right now, it's those of us in the pro-life movement that are actually leading that call.
Yeah, and I mean, it's shocking that if you truly care for women, obviously you wouldn't advocate for abortion, but even those who advocate for abortion should at least want women to be safe, right? And this is not safe. This is substandard care.
Right.
What does authentic informed consent actually look like, and how is it lacking in the current system with the mail order abortions?
Yeah. Well, so, the basics of informed consent, which is a basic tenet of medical ethics, is that we have to give our patients informed consent. We've moved out of sort of the paternalistic era of medicine to just say, just listen to what your doctor says and don't ask any questions. That was the paternalistic area. That's kind of what the abortion industry has gone back to, because informed consent brought us out of that. And informed consent says that we talk about the risks, benefits, and alternatives of anything that we're recommending to a patient, whether that be a drug, a therapy of some kind, or a surgery. We have to talk to them honestly about the risks, the benefits, and any potential alternatives that are out there. Of course, that's not being done. I would say in the abortion industry as a whole, Planned Parenthood isn't doing informed, when 9 out of 10 pregnant women leave Planned Parenthood having had an abortion, I would guess that fully informed consent is not happening there, where they talk about the benefits of pregnancy, the risk of abortion, the alternatives to abortion, things like that. So that absolutely has to happen for any truly medical intervention, which I think is yet another evidence of the fact that the abortion industry is not actually providing medical care. They are providing abortion. They're not providing medical care. If they were, they would be fine with the same regulations that the rest of us in medicine have, and they would be all for and promoting fully informed consent, which they're not.
Mm-hmm. What does truly compassionate healthcare for women facing an unexpected pregnancy look like?
Well, I think this is something that my colleagues at pregnancy centers actually do so well, is they come alongside of women. They don't condemn them for contemplating abortion, and they see them where they're at, figure out the space where they truly are, figure out what's going on in their life, and then say, what can we do to help empower and support you and help you make the choice that is going to be the best for you and for your baby? And we know that that actually doesn't involve abortion, because that is going to harm you. It's going to end the life of your baby. We know that it has lots of long-term physical and mental health implications for you. And we want you to feel supported. We know that the vast majority of women who choose abortion say that they would have chosen life for their baby had they had the support that they needed. So actually coming alongside of them, providing them with that support, encouraging the father of the baby to be involved as well, and trying to loop him into that process is actually the best compassionate care that we can provide for women. And then, of course, looking at, what does this look like for you? Does it look like parenting your child? If so, great. Let's come alongside of you and help you be the best parent you possibly can be. Or does it maybe for that particular family look like placing that child for adoption? And then walking them through that process as well. That is what truly compassionate care looks like. It takes a long time. It's not a 5-minute visit. What is a quick visit is, oh, you want an abortion? Okay, I'm not going to say anything to you about it. Here's the number for your local abortion provider. And oftentimes that's what's happening. And that doesn't get at the root of what is causing the issue. Why is she contemplating abortion in the first place? And that's really what we need to get down to. It takes longer. Having done it in my office, it does take longer, but it's what women need. And I'm so thankful for my colleagues at pregnancy centers across the country that are coming alongside many times when I didn't have the resources within my office to help a patient with everything that she needed. One of the first connections that I made for her was to our local pregnancy center, who I knew could get her connected with all of the support resources that she needed. And that's what truly life-affirming healthcare looks like. And I think, if we asked women if they were honest, that's the kind of care that most women actually want. It's just unfortunately not the care that they're finding oftentimes, and certainly not when they show up at a Planned Parenthood or not when they go on a random website. That's not the kind of support and care that they're getting.
That's right. And also there have been studies done where it's women who don't feel that they're supported either by their partner, or their boyfriend, husband, or their families or communities are the ones that are most at risk for abortion. So if we can help women find the community and find the support they need from within their family, a lot of them would choose life instead of feeling cornered in to get an abortion. Finally, after everything you've witnessed as a practicing OBGYN and through this investigation, what do you hope every American understands about what is happening with mail-ordered abortion pills today?
Yeah, absolutely. Well, I would want every American to understand that this is not telehealth. It's not telemedicine. It is not healthcare or medical care in any way, shape, or form. Pregnancy is not a disease. And these drugs that have as their only intent to end a pregnancy, end the life of an innocent human being, that is not medicine. It's not healthcare, and it's not medically necessary. So, one, it's not needed. And two, the way that it is being dispensed is actively endangering. Not only is it leading to the deaths of more and more preborn children every year because these drugs are now so easily available online, but it is also actively endangering the lives of women and girls, and it's enabling abusers. This should be something that unites all of us in this country, regardless of our position on abortion. We should be united in the fact that this is dangerous. And we should all be concerned that the FDA, who has been tasked by Congress to ensure that any drug that is approved not only is safe, but also is safe in the way that it is being used, we should all be alarmed that the FDA has continued to rubber stamp the use of this high-risk drug in this even more dangerous way. And so we all should be calling on the FDA to publish the results of its safety review, that they be transparent in the way that they publish their data and who conducted the review, and that we take a serious look at the damage that this drug is causing, especially in the way that it's being dispensed, and that the FDA be committed to taking action as soon as the results of the safety review are out to help improve the safety of women and girls. Of course, these drugs at their baseline are inherently dangerous, but they are especially dangerous in the way they're being dispensed.
Well, thank you, Dr. Francis, for sharing your expertise, and also as a hospitalist, you've seen this in person, and thank you for advocating for both women and babies.
Absolutely. Thanks so much for having me on. It was great to be with you.
For my conversation with Dr. Christina Francis, a board-certified OBGYN, CEO of the American Association of Pro-Life Obstetricians and Gynecologists, and a practicing OBGYN hospitalist, who went undercover posing as a 13-year-old girl with multiple serious medical risk factors to test today's mail-order abortion pill industry. Here are 5 key takeaways. 1. Mail-order abortion pills have eliminated critical medical safeguards. Abortion pills could be obtained online without meaningful medical screening, age or identity verification, confirmation of pregnancy or gestational age, an ultrasound, or a real-time conversation with a qualified medical professional. These missing safeguards place women and girls at unnecessary health risks. 2. The abortion pill is not, quote unquote, just like a heavy period. Women can experience serious complications, including hemorrhage, infection, retained baby parts and pregnancy tissue, and undiagnosed ectopic pregnancy. There is also emotional trauma many women report after experiencing a chemical abortion at home. 3. Women deserve the same standard of medical care as every other patient. Authentic informed consent requires an honest discussion of the risks, benefits, and alternatives, along with individualized medical evaluation and follow-up. Women seeking abortions should be informed of the risks and alternatives and receive the same level of medical care and oversight expected for any other potentially high-risk procedure. 4. The FDA can restore safeguards while continuing its safety review. The FDA does not need to wait for the completion of its review of mifepristone before acting. It can immediately reinstate safeguards such as in-person dispensing, physician oversight, and ultimately require ultrasound evaluation while conducting a comprehensive review of real-world safety data. 5. Compassionate healthcare supports both women and their preborn children. Women facing unexpected pregnancies deserve personalized care, practical support, and compassionate counseling rather than a system that simply sells abortion, increasingly without any oversight or medical safeguards. Healthcare should address the underlying needs that lead women to consider abortion to begin with, while protecting both mother and child. Because truth matters and human dignity isn't optional. This is Bioethics, Babe. Thanks so much for listening to this episode of the Bioethics Babe podcast. If you've enjoyed this content, please subscribe to my YouTube channel and your favorite podcast platform, and share with your friends and family. Also check out bioethicsbabe.com for the latest episodes and resources.